Hello everyone, good afternoon. Let's enjoy the chest radiographs with Dr. Y. Session 10, Pneumonia. I'm Dr. Y, chest radiologist working as a medical professor in Department of Radiology in Korea. Today we will study pneumonia and we will focus on lobar anatomy too. Let's begin. Before starting pneumonia, let's review the session 9. We are familiar with this film, this imagery, this radiologic findings. Now I will say words and you point where it is. Okay? I think you will do it quite well. Yes, first, cardiomegaly. Yes. Blood diversion of upper part. In other words, cephalogization. And third, vascular cuffing. And interstitial edema. And then many Curly's B lines. And also we can find some small pleural effusion. Very good. Yes, this is the case of congestive heart failure. Second case of session 9, congestive heart failure. Yes, this is cardiomegaly, big heart. Cephalogization, vascular cuffing, interstitial edema, Curly's B lines. What is this shadow? Carinae angle widening. Yes, this is left atrial enlargement from mitral valvular heart disease. Congestive heart failure from mitral valvular heart disease. Let's start our main game. Pneumonia, focusing on lobe segmental anatomy, is inflammation of the air spaces and or interstitium, for example, due to infection as in bacterial pneumonia. Let's begin the first case. This is frontal radiograph of a young man. What do we see? In upper lung zone, we see haziness or consolidation with bronchus. That means air bronchogram. Air in the bronchus surrounded with something filled alveoli, and lower border is minor fissure. Yes, this is upper lobar consolidation suggesting pneumonia. Minor fissure is here and major fissure is here about. So this is definitely right upper lobe pneumonia. What about this right lateral film? Does it match with your imagination? Yes, right upper lobe lobar pneumonia. We see minor fissure accentuated and airspace consolidation above that. That is right upper lobar pneumonia. What do we see with this frontal radiograph of a child? Yes, consolidation here, maybe here, around here. We see minor fissure. How about right heart border? Where is this pneumonia involved? Yes, that's right middle lobe. We see right minor fissure anatomy and obliteration of right heart border. We call it silhouette sign. so it must be right middle lobe. If you are not confident about this diagnosis, please go back to session 2, normal anatomy, or session 6 about silhouette sign, and then come back, please. How about this lateral film? Does it match? Does this concur with your idea? Yes, we see triangular shaped consolidation. Upper border is minor fissure. Lower border is major fissure. That's correct. How do you feel with this film? Please look closely and slowly, and please find out what's the difference with the previous right middle lobar pneumonia. You got it? Consolidation here to here and here. What's the difference? Minor fissure is not remarkable, and right heart border is clearly visualized, and air bronchogram here at retrocardiac area with dense retrocardiac area. Correct. Right lower lobar consolidation of pneumonia. Are you confident about silhouette sign? If not, please go back and review again session 2 and session 6. Let's imagine the next image of lateral film. How about this lateral film? Was this concur with your idea? Yes? Good job. We see only one hemidiaphragm here. Which side? Okay, this is left side. And how about retrocardiac area density? Very dense. Dense consolidation here in posterior triangular area. Okay, correct. Right lower lobar consolidation of pneumonia. How about this young woman's frontal chest radiograph? What do we see? Okay, just look closely. Left upper lung zone is clear, okay, but retrocardiac area is dense. Retrocardiac normal pulmonary vessel artery veins are not visualized, okay? And how about the border of descending thoracic aorta? Obliterated. And paraspinal lines obliterated. How about left hemidiaphragm? Obliterated. And left cardiac, left heart border. It looks okay. And heart border, heart is anterior location. Aorta and paraspinal line is posterior location. So we can imagine where this consolidation is involved. That's right, left lower lobar pneumonia. We can confirm that this is a left lower lobar pneumonia with this lateral film. Yes, very similar with the previous lateral film, right lower lobar pneumonia, only with one difference, hemidiaphragm. Yes, we are now seeing with this patient the right hemidiaphragm, right? That's the only difference between right and left lower lobar pneumonia in lateral film. This film is quite interesting and somewhat philosophical. Let's enjoy very slowly. What do we see? Diffuse airspace consolidation and air bronchogram on the left side. Somehow we do not know where each lobe, upper lobe, lower lobe, or whole lobe. But if we see closely, we have some clues. How about the aortic arch? The margin is clear with a black line and some normal small airspace. And what about the left heart border, obliterated? And how about CP angle area, somewhat alive? And what about the aorta line, descending aorta? It's preserved. That means upper lobar involvement. This is left upper lobe pneumonia. First of all, about aortic arch level is, have you ever heard the Luftzickel sign? That's German word. In English, Ehrsichel sign. That is the anatomically left lower lobe superior segment. That means, in this case, left lower superior segment is okay. And aortic line is okay. That means left lower lobe is okay. The next day, the patient went from bad to worse. What do we see? Yes, aortic arch is obliterated. That means superior segment is involved, and aorta line is obliterated. That means posterior portion of lung. That means left lower lobe is also involved by pneumonia. And we see the clues of aggravation by intubation tube, central line, and CP angle pleural effusion. So this case is from left upper lobar pneumonia to left whole lung pneumonia, from bad to worse. From this slide on, we may confront with some difficulties about localization of anatomy, lobar anatomy, because the silhouette sign has one precondition, that is whole involvement, not partial involvement, homogeneity of the pathology. Okay, let's start with this patient. We see consolidation in middle lung zone. Left heart border. How about left heart border? It is somewhat preserved. Retrocardiac area is okay. Aorta line is okay. Diaphragm is okay. Aortic arch is okay. Where is this lesion? We guessed this lesion in a left lower lobe pneumonia because heart border is preserved. But what's the result? What is the truth from the lateral film? Yes, it's upper lobar pneumonia. What happened? This is the actual lung window setting CT image. We see the left upper lobar pneumonia involving middle and lateral portion, not medial portion, not touching the left heart border. That's why we don't see the heart border obliteration of consolidation in frontal erect radiograph. That made us confusing to misdiagnose as lower lobar pneumonia. It's interesting. Now we are going deeper and deeper into the lobar and segmental anatomy and the silhouette sign. Maybe we have met this kind of image before in anatomy session of session 2. What do we see? Yes, preserved right minor fissure and obliteration of right heart border. What this means? Is it right middle lobe? Yes, I know your answer. Yes, this is partial involvement of right middle lobe. Maybe medial side involvement, so it is medial segment of right middle lobe pneumonia. Now we see the coronal lung window settings chest CT. We see the normal portion of right upper lateral portion of middle lobe and consolidation of medial and lower portion of right middle lobe. We know why that was on the chest radiograph like that. Actually, lateral segment is upper location touching minor fissure, and medial segment is lower medial location touching heart border. So this is medial segment pneumonia of right middle lobe. I'm sure you remember this image before, maybe in session 2 or session 6. Let's forget the left side lesion and just watch right middle lobe lesion. How about the findings? Right minor fissure is involved, right lateral upper portion consolidation, preserved right heart border. What is that? Yes, lateral segment involvement. Let's confirm. This is actual lung window setting image of middle lobe. This is lateral segment bronchus. Lateral segment is involved by pneumonia, lobar pneumonia, alveolar pneumonia. This is medial segment bronchus. Medial segment is okay. That's lateral segment pneumonia. What about this image? Airspace consolidation around here. We know minor fissure is about here, major fissure is about here. So, consolidation including below the major fissure means outside the major fissure. That is, yes, lower lobe pneumonia. Lower lobe pneumonia. Is that correct? Concur with your idea imagination? Yes, partial involvement of right lower lobe. Now, the study of session 10 is ended. We studied very important and hard stuffs of the chest radiography, lobar anatomy, and pneumonia. That is very, very important. We must praise ourselves for our hard effort. Yes, let's be light about this quiz. Answer for the quiz. Juxtaphrenic peak. Are you correct? Juxtaphrenic peak. Peak around the diaphragm. Juxtaphrenic peak is a small triangular opacity based at the apex of the dome of a hemidiaphragm associated with upper lobe volume loss of any cause. Fractional society. This is after right upper lobectomy of adenocarcinoma, and there is a juxtaphrenic peak, means volume loss of lung. This is the last slide and quiz for the next session. She's an old woman, have no difficulty, no symptoms. What is the diagnosis, or just what is the finding? See you next time. Bye-bye. Like, subscribe will be a big support to me. Thank you very much.